Hi everyone, I hope you're all doing well and staying safe. My name is Krupa Patel and I'm the founder and president of Dental Shadowers. I'm very excited to introduce a new virtual opportunity to you all that was shared with us by Devin Hurd, Vice President of the ASA chapter at Texas State University. This video is the first of our virtual procedures series. This series will include video recordings of dental procedures performed by dentists. Although we cannot confirm that these hours will be accepted as shadowing by all dental schools, we are aware of some dental schools that are accepting these virtual opportunities as shadowing. It is best to check with each dental school before documenting these experiences as shadowing on your application. We recommend listing this as academic enrichment, and more details about how to document these virtual experiences can be found in our Introduction to Dental Shadowers video on our YouTube channel. As mentioned earlier, this opportunity was shared with us by Devin, and all of the videos in this series have been filmed and organized by Devin. I will now pass it over to him to explain the content of this video.
Thanks, Krupa. Hi, everyone. As Krupa said, I'm Devin Hurd. I'm very excited to share this opportunity with y'all. We hope you find it helpful to watch dentists perform procedures and to learn more about the steps involved and other dental knowledge from the dentists themselves. This video was shared and helped by my mentor dentist, Dr. Matthew Heck of Smile Creations in Austin, Texas. We will be observing an implant scanning of an interior implant crown. So at the end of the video, to verify your virtual shadowing hours from this recorded procedure, there's going to be a short quiz from which you must answer 6 out of 8 questions correctly and provide a summary of the video. The link to the quiz is in the description below.
And I want to thank Devin for organizing and filming these procedures in the series and sharing it with us so we can make it accessible to pre-dental students all across the country and even some internationally. And I want to thank Dr. Heck for allowing us to virtually shadow him and the patient for allowing us to post this recording. Thank you all for tuning in, and we hope you enjoy.
All right, everyone, so we're going to be scanning today for an implant crown, assuming my software opens up. It's been a bit of a goofy day around here. This is an anterior implant, so there's a couple of extra steps that we'll be taking to make sure that this goes well. When I was just explaining to Devin, one of the things that we want to do is we want to make sure that the tissue, gum tissue around the implant has been formed in a way that looks natural, especially the front. So sometimes you get lucky, and let's say if it's a broken tooth or an abscess tooth that needs to come out, but the gums are in good shape around it, they basically, you can just put a healing cap on the implant immediately and it preserves the shape of the gum. And so when you go to make the final crown, you just unscrew that healing cap, scan, and you can put a new crown in right away. In Walt's case here, that wasn't the case. What did you have there before we had before the implant was in? What was in that space?
I didn't have anything in the space, and that's why we got braces. So we had to create space with the braces, and then had a contact in there.
Right. So you had the tooth had been missing ever since you were how old?
I was 11, and it was missing until I was around 18, 19.
Okay. So in Wolf's case, the spacing wasn't right. There was no tooth there. Of course, the gum and the bone ridge weren't adequate. So the orthodontics had to be done to correct the spacing, get everything set up just right. And then finally, Cassie, grab my camera. And then finally, the implant placement. There's usually, when you put the implant in, there's still some insufficient gum or bone around that, especially if the tooth's been missing for a long time. So there was some grafting done at the time and some steps that the oral surgeon took to get it to kind of plump up and look as full as possible. And this is what we had. So I don't know if you guys can see that, Devin. So this is basically what we had, how I received it. So, you know, pretty good gum, still not like a very natural contour. And even you can see from the occlusal view, you know, just didn't really have quite the contour we wanted. So a lot of cases with these anterior teeth, we will make a custom provisional implant crown. So this is just a little shade tab, but we're trying to get a good match of color to the adjacent teeth. But the idea is I needed to put something in that place. And so this is what he's had for the last few months. You can still see some of the metal from the connection to the implant. That will be not visible when we go to make the final, but that's something we've had to have for this kind of interim stage here. So this is our temporary tooth. You know, if you look at it, you know, the gum tissue was kind of collapsed. So what we had to do is we had to bring them in a couple times, basically kind of add and reduce on the implant crown until we kind of contour the gums and get them to look as natural as possible. They're still not all the way there, but they're a lot closer than they were when we started. So the idea today is we'll get started, and on the final restoration, we're going to scan the tissue, scan the implant, and then we'll put the temporary crown right back in. Before we start, let's see, Cash, I think I had the shape that I had in page one. That's a big three. So what I'm doing is I'm checking on the shade. Yep, we did a Vita A3. So whenever you're doing an anterior tooth, whether it's a crown or a veneer or an implant, you want to make sure that you match the adjacent teeth as well as possible. Yes, we have I don't need a master guide, I don't think.
It's better horizontal and vertical.
So first off, any photography that you do, any shade matching you want to do before you start the procedure, the teeth will dehydrate very quickly. So let's say you're in there and you're working and you're getting everything ready for the new crown or veneer, and then you remember, oh shoot, I forgot to take the photo. You actually probably want to just finish out the day, let them go, and wait at least 24 hours for the adjacent teeth to rehydrate. Because if you were trying to match to other teeth, it's going to be off. They change color after being exposed to air. So we'll get a couple of pictures right off the bat here before we even has started any of this, and that'll give us our most accurate match. We'll just give you a smile. Kind of look up a little bit and move your head this way. Cool. I strongly recommend for all of you who are looking into getting into anything a little more sophisticated in dentistry, to get yourselves a decent DSLR camera with a good quality macro lens and a ring flash. It'll make a big difference towards getting good imaging rather than using a little internal camera. However, I will say I have seen some pretty amazing pictures with some of these new iPhones lately. So that's not to say that you can't get a good outcome with some good lighting and a brand new iPhone, but I still like to go old school here. Okay, I'll go to open now. But back about halfway. Cool. Okay. Go ahead and grab that Vita guide here. Yeah, I think I'm probably going to use Summit for this. Just due to the incisal translucency. So I don't know if this will pick up, but let's see if I can get a little closer in. So with a good quality camera, you can see how much you can pick up as far as the shading. You look at the incisal edge of these teeth, you can see through that kind of incisal translucency, you can see the different lobes of development in the center of the tooth. So it's a lot more complicated than just picking a solid color. You can see the one next to it, which has been our temporary tooth, how simple that one is. It's actually gotten a little bit lighter over time. So that's the value of having these good cameras, as you can send these to your lab technician and they can use all their equipment and artistry to match Mother Nature. Let's take a picture. Look up here. What'd you pick? A3. Actually, not that far off. I figured since we're using, these are a little bit too gray. Not bad. Funny, I actually like the A3. Cool. Do that. Hold that. So you can hold this up. Yeah. Whenever you're taking a photo with the shade tab, you pick the ones that look the best, and then we'll open. Close about halfway. Perfect. You want to hold it edge to edge like that. See if you can get the label of the shade in the photo. In this case, it's just a simple Vita A3, which is one of the systems that we use. Smile again. And off the edge a little bit, Ken. Good. Winner. Excellent. So again, you can see this is about what you want. You got the edge to edge of the photo tab, you got the shade, and you got the label of what the color is. And they can get a good idea of whatever custom work they need to do. Okay? All right. That was fun. Like that. All right, let's do some dentistry here. So depending on the system that you use, if you're just kind of going old school, you'll have a putty mold that you'll take. You'll take an impression post that is whatever the implant is. You match an impression post to the implant. You put it in, lock it in, take an impression of that, and then you send that off to a lab. In our case, we're going to be doing this digitally today. For a lot of reasons, I like doing digital scans for most of our work. It's more predictable. There's no distortion. And for implants, there's some extra features that we'll go over today that make this just a lot more of a seamless transition into a final restoration. Well, let's do this. So with any of these technologies, they'll basically walk you through what do you want to use. In our case, we're probably going to use material called Emax or lithium disilicate ceramic. It's basically a reinforced glass ceramic, and we'll probably be cementing that onto a zirconia-based abutment. The abutment is kind of like what acts as like the tooth that screws into the implant, and you glue the crown onto that. Final shade is actually a Buddha A3. Okay. And then we have to call it an implant. They'll ask you what the scan body type is, so that helps the lab communicate to you what exactly the implant itself is, so they can design the connection. So in this case, it's Novell, crown connection, regular platform. And if you're designing it in-house, if you're milling a crown in-house, you can do this on what's called a tie base, which is basically the little connection that goes into the implant, and then you design everything off of that. In this case, I'm scanning the post and sending it out to the lab. We got our material, the ceramic, final shade, A3. Or we can do gold. Well, you want to do gold too? I can.
I think I'm good.
Oh, you're good? Okay, all right. We'll go ceramic. Excellent. Okay. So now we'll get ready to do our scan. Usually what I'll do is I'll do everything that I have to before we do the implant scan first. So we'll scan the upper jaw. We'll scan the opposing jaw. We'll scan the bite. And then we'll get ready to do the final implant scan. All right, dude. You ready? You excited as I am?
I don't know.
Yeah. I'm pretty happy with the way the gums look, to be honest. I think that's a great outcome. It would be nice to get the shade of the tooth to match a little bit better now. Give that Vita Jeff. I tend to second guess myself on shade throughout the appointment, so they're used to that at this point. I still think that looks good. Good. Yeah, and part of the reason why we see this gray here because this is on the provisional temporary crown that we made. It's resin based, which is basically like a plastic that's very translucent, and underneath you can see that titanium base that connects to the implant. So it's kind of an illusion that will be all concealed with the permanent restoration. Okay, very good. Yes. So first thing I'll go ahead and do is I'll just scan the lower arch. Most technology now, you don't need to, when you're scanning, you can just go straight to scanning the teeth, and even some of them do like a shade match for you. I don't really count on that. I still like, there's a little powder. This is a little zinc oxide powder that they give you to spray on the teeth, just to give a little puff of that to give the computer a little more definition. And all that does is,
I was just trying to get some
go for it.
scanning screen as well.
Restart that. That's more water. Everyone's got their own sound that they pick to tell you if the scanner is behaving itself or not. Sounds like it's scanning well. In this case, for a single unit anterior tooth, you don't have to scan the whole arch. Actually, if you put too much information there, sometimes it can kind of stall the computer. That is plenty of what we need it for. Okay, good. And I think I'm going to go ahead and scan now. I could do a biocopy. Depending on the tooth, bite down one. Open. I think it's a little bit too prominent there. Right? So it kind of depends on what you're doing. Sometimes if you feel like, let's say this this natural tooth was they were both natural, and then for whatever reason one of them was having to be turned into a crown or eventually an implant. I could scan it, and then I could do what's called a copy or biocopy. And basically that just gives the lab a reference when they go to design the crown. The software will start with the original tooth. In this case, some contour things I don't love about this tooth. I think I'm going to do it anyways. I'll do a copy, but I'm probably going to have them do some revisions on that. I think I'll do a bio reference. So instead of a copy of the tooth, we'll do a reference of the tooth next to it. Symmetry is a big deal in our face and our teeth. So ideally, we have them actually just literally copy tooth number 8, which is right next to it, and the computer will spit out a mirror image of the software of tooth 8. That way, they can do the same. Everyone's got their own technique. If you look at the scanner now, you can see that I kind of like wave the one back and forth so I can get underneath all the different undercuts. Cool. All right, so that's my reference scan. And like I said, I'll just ask them to essentially make a mirror image of number 8. My only concern with this case, which I may have to do a little revision, is the space between the width of the space for the implant crown that's going to go in this tooth. This may be a millimeter or so wider. So they may recommend that I add a little bonding of composite to tooth number 10 when we go to deliver this. The main thing is that these need to be mirror images. So we'll just kind of see how it comes out. Overall, though, I think we're going to be in pretty good shape. A lot of this extra stuff the computer will clean up later. I'm not really worried about it. I think it's time for us to go ahead and rinse you out and take our provisional out. Put together. You'll be. Yeah, the company has its own set of tools. They finally got smart and all these extra companies, they started to design their screws and abutments to be compatible with other systems, so I don't have to have 10 of these hex wrenches and all these different types of connections. So there are two basic systems, one from Nobel and one from Straumann, that work with almost everything we have. Still, occasionally you'll have to get a different set of tools, but generally what I have with those work well. For an implant torque wrench, you've got the wrench, you've got this little driver, and basically it's just a little hex screw at the end. Snaps in, you kind of tighten it, and then this little lever tells you how tight you're making it. Usually would go like this, and it tells you how tight you're making it based on Newton centimeters. It takes you back to physics. So if there's a little gauge here that tells you how tight you are making it. You only want to go to a certain distance, around 15 Newton centimeters for temporaries, and all the way to 35 for final restoration. And then if you're placing the implant, you can go all the way up to 50 to 70 Newton centimeters when the implant itself is getting placed by the surgeon. So we'll never go that tight, but that's an idea of what we're doing there. Okay, so let's go and take this out and go from there. Try to remember where our access is. Good deal.
Yeah, you should have.
What's that?
I need like a selfie stick.
Yeah. I'm going to hold that back a little bit. You're going to get some spray on it.
Coming close.
There's a filling that I had to place. The filling that I had to place to seal the the hole here. Try to place it with a different colored composite than the original, so I can actually see the difference. So I put a little darker composite back here. That's good enough. I can get through this. When it comes to the ways to secure an implant crown to an implant, there's two general ways. You'll always have the abutment or the connection to the implant. The question is, can you have the crown and abutment cemented to each other from the get-go, and then you put the whole piece in as one unit, screw it in through this hole in the back of a crown or the top of a crown, and then fill the hole in. That is generally preferable now because we understand that the number one cause for implant failure is excess cement from doing it the other way, which is when you have the connection, put the connection or abutment into the implant and then glue the crown on. Unless you're really careful, you are nearly certain to get at least a little residual cement down the tissue. If it's too much, it can cause the implant to fail. So in this case, we got lucky just the way that the angle of the implant is, at least for the temporary phase, we could make this screw retained. I was explaining earlier to Devin that our front teeth, the roots don't just go straight up; they're actually at an angle. They angle back towards the palate, and so the screw hole has to come out the long axis of the implant. So we're kind of right at the edge as the angle comes out. If it's placed any more than that, the hole would have to come out through the front, and that's no bueno. In that case, we are kind of stuck with having to do it the other way, which is you put the abutment in and you have to glue the crown on so you don't have a hole in front of the crown. We'll have to kind of see how this one comes out. Yeah, it should be good. Should be able to get to it. Okay. All right, kind of opened up our access and make sure I can get our driver in there. And I think we are about ready to go. So what we'll do, one of the reasons that I said we like having these scanners is that we've gone through all that work to kind of shape the gums around the implant, and we don't want to lose any of that. When you take the temporary crown out, the gums immediately start to collapse. There's nothing holding them. Within a few minutes, they even start changing morphology. So what I'll do is I'll do a gingival mask, which is basically a copy of the gum tissue. And so that will allow the technician to essentially design this so it emerges out of the implant along the gum design that you made. So have our powder ready. Probably we'll need our torque wrench to unscrew this. Well, you're going to feel a little pressure. I'll pop this temporary crown out and we'll do our gum scan, and then we'll put the pressure coping in. Feel the pressure. Good. Okay, so unscrew this. Go. Do a click. You'll know you've gone far enough. Good. Implant didn't come with it. That's always a good day. Kidding. All right, powder. And let's scan right away. Of all the features I like about digitally scanning, this is one of my favorites, is that copying that gum tissue. Any of our more seasoned dentists that have done a lot of anterior implants will tell you doing this the analog way with some putty is really challenging to try to recapture that, because even now as I'm talking, that gum tissue is collapsing. And by the time you get the impression post in and you take an x-ray and it's all good, and then you take the mold and it's setting, that gum tissue is collapsed sometimes up to 25 to 30%, whereas that will allow us to scan it right away. So you can see, if you look, you can see how much different the gum tissue looks around that than it did before, when we just had that little gold healing cap in there. It's a big change. So that's why we went through giving him a temporary tooth. For him, I think he was just happy to have a tooth. But for us, we wanted it to look and be shaped just like real gum around a real tooth. And I think we got a pretty good outcome here. Take a photo.
Definitely wanted to be done first, huh?
Yes, that's right. Kind of have to deal with this again, huh? You see a little cleft in the back. That's okay. Pretty big change from that little cylinder that was in there. You can kind of see symmetry-wise. Pretty nice. Okay. So we've got that scan. Let's go ahead and, before I forget, let's scan our bite. There we go. Perfect. So link the two models together. And last but not least, we're going to put our scan body in. So like I said, every implant system has their own independent set of impression parts and restorative components. In this case, we are doing a Nobel active implant. There's cheat sheets to all this to tell you exactly which ones you need to use, but in this case, we've got lucky. It's the most common implant that we restore, which is a Nobel implant that has a conical connection, so meaning the way that the abutment, or in this case the impression coping, fits into the implant. I'll show you guys. It's kind of hard to see. We have to show you some pictures. There's a little hex connection on the inside. So this is a kind of the analog of the implant. A little hex connection, and then the cross section is conical. And so that hex helps you lock it in together. And then it's basically a cone-shaped base to your abutment that slides into that circular connection of the implant. So it gives it a good seal, and that'll be how this is designed. That's one of our more favorite connections, is that conical shaped connection. So double check that I've got the right one again. Very good. All right. So since it's a hex connection, there's 6 different ways to align this. That just sit in that way. I'm going to rotate it sit in that way. You'll see this is for this system, which is a Sirona CEREC scanner. There's a little notch that is on just one side of that impression post, and it's better to put that notch where you can see it, so pointing outwards. All right, it's not essential, but at least helps you align and know that you're in. So you can kind of pick it up, rotate it until it locks in. Okay, so that's where I'm fairly certain we're in. I'll go through, tighten that into the implant. Very good. Just hand tighten for now. And before we do our final scan, I'm going to sit him up. We're going to take an X-ray, and always want to do this step to confirm that the impression post, or in this case scan post, is flush with the implant. Super critical. So sometimes you think you're in. Walt, just kind of lightly close on this gauze here. That's sticking past your teeth, so if you sneeze, don't bite down, okay? All right, I'll sit you up to take an X-ray. You always want to make sure that this piece is flush. If it's not, if it's sitting up weird into the implant, and you scan it and you think, okay, our day's done, the implant's going to come back and it's not going to, or the crown's going to come back and it's not going to fit right into his bite and smile. It'll fit in the implant okay, right? Because you picked the right implant, but if that piece wasn't flush, then your impression is going to lie to you. So take an X-ray. Any competent lab is going to ask for a copy of this X-ray to confirm that the impression coping fits. That way they're not remaking this for you and having to waste their time. Yeah. Take an X-ray and see how this looks. Any questions?
Oh, here's one from start. Here, Hazel, do you want to read that one out?
Yes. From start to finish, how long does getting an implant take on average?
It's a good question. So kind of depends. Depends on the quality of the bone. So let's say you have, we were just talking about this earlier, if you have kind of a slam dunk case where it's just, let's say a lower first molar that's recently extracted, a year ago, it's a big fat pad of white bone. I mean, you put the implant in and you can restore it within 2.5, 3 months. Let's say you have a situation like this with an anterior tooth. Well, let's say the ridge needs to be grafted. You don't have enough adequate bone. That's a 4 to 5 month healing period at minimum. Sometimes it takes a second graft. Then you place the implant. 3 months is the typical integration time if it's going into healthy bone. So you're getting up to maybe the 8, 9 month mark. And then we're making a provisional. Then you have to make that, restore it, shape the tissue over a few months. So it could be up to a year between the starting process, the ending process of an anterior tooth before you're putting the final one in.
Oh, wow.
But in a typical scenario, you'll have a tooth that needs to come out. If it's a single rooted tooth, oftentimes you can take that out as long as the bone is of good quality. You can get the implant in the day the root comes out, which cuts that time down dramatically. So then you have your 3 month integration, and then you can restore it at the end of that. Oftentimes, if that doesn't happen, you'll have let's say the bone is of not good quality, or it's a multi-rooted tooth. In a lot of cases, like a lot of molars, you take that out. I mean, do you imagine it's like you're putting a bolt into wood? If you've got all these pock marks and holes in the wood, you're trying to get good torque with that bolt. You're going to have a hard time. Yeah. So usually it's best, unless it's a single-rooted socket that has good bony outline all the way around, it's usually best to graft it and let it heal. So that's the long answer. The short answer is depends.
For I saw the insert point was on the back of the tooth. I've seen them where it's on the front. Is it more common to have it on the back so you don't have to have like that shading?
It all depends on the angle of the implant, right? So
okay.
If you imagine, the tissue comes out this way, the teeth are kind of coming out and they curve down.
Yeah.
So the angle of the implant's it's always gonna be at a, you're hardly ever gonna have an anterior implant that's straight up. You really never will. It's just some weird Mauser shape. Yeah. So it kind of depends on as the tooth of the crown emerges out of the implant, the tissue. When you're going into that hole, it's all about the long axis of the implant. The implant's like this, there's a good chance you can have the hole in the back of the crown. If it's like this, that's what I was saying. The hole may come out of the front of the crown. In that case, you don't want that. Yeah. You don't want a big filling hole that's filled on the front, which can stain and look irregular. Yeah. So in that case, you'll have to make a custom connection. It's called a custom abutment that you screw in, which may have to happen here. It depends. You screw that in, and then it looks kind of like a prep tooth. And then you will glue the crown onto that. And like I said, if we can avoid gluing crowns onto implant abutments, that's best because the seam is underneath the tissue. It can the cement can kind of flow under, get on the implant, and that's where you start getting in trouble. So we always prefer screw retain. If you're in a posterior tooth, you can almost always do a screw retain crown, right? Because the long axis of the implant is perpendicular to the bite plane, right?
Yeah.
So you can, I mean, there may be some angulation issues, but you're almost always going to be able to do screw retained with the posterior tooth. But anterior teeth, especially upper anterior teeth, you end up having to do those custom abutments more often than not.
Yeah.
In my opinion. So,
Cool. Thank you.
and when you do that, you do have to make sure if you are going to have to do a custom abutment, like in this case, so let's say we have to glue it on. Anytime we have to cement an implant crown onto an abutment, you don't want the edges or the margins of that abutment way under the gum, right? Because then you're going to have a hell of a time trying to clean it. So you ask the lab, I want the margins of my abutment to be maybe 1 to 2 millimeters subgingival, so right under the crest of the gum. Okay.
Okay. Yeah.
So then when you go to glue the crown on, it's easy to get to that seam to clean the extra cement. Okay. So that's pretty important. You don't want it right at the crest because then if there's any recession of the gum over time, it'll show the seam. So maybe a couple millimeters down at most.
Yeah. So that way the gums can come down and
that's right. Yeah, the gums will still seal it, but you're not your edge of your crown isn't so high that when you're trying to fish cement out, you're in trouble.
Yeah.
You can't quite see it.
Having to dig.
And I'll even pack a little nylon cord in there, like when I'm prepping a crown. I'll pack a cord when I'm delivering an implant crown around the seam of the abutment.
Okay.
Does that make sense? So that way it catches any of the cement that's going down, and then I tug that out after the.
And it pulls it all out.
But it's still kind of a messy process. And you'll go to lectures and they'll show someone who's being really intentional like that. You can make like a little custom coping to kind of put into the crown and drag out most of the cement, so it's a really thin layer of cement. Do all these steps, and then they'll do like analysis of that, and you'll still see a little film of cement that kind of seeps up in the tissue with the fluid. So
wow. Okay.
whenever you can screw it in, screw it in.
Yeah.
All right, buddy. How'd that work? Good. Very good. There's a certain appearance that you want to see. You don't want to see any spaces between the connections. You want to see the screw is holding that in well. Looks great to me. Implant looks well submerged. So that looks good. So we'll go ahead and scan the implant crown now, and we'll get ready to put the tooth back in. All right. So different systems, they have different ways of doing this. For us, we have this Nobel system. They have this metal scan post and then this little rubber, it's called a scan body. This is actually what the computer recognizes. And then we just tell the computer in the beginning what the implant type is. So you can see it kind of locks on there. That little notch that we talked about that's on the impression post, it kind of fits directly on with this little plastic housing. It's really critical that these are well aligned. You can have it twisted even just a hair left or right, and that can alter the way your implant fits. This is basically the moment of truth. This is exactly flush with the post and lined up perfectly. I think we're good to go. Okay, cool. All right. If you want to put the section. Another reason I like that powder, not only does it give us a little more definition on teeth, but let's say you're scanning someone's mouth. They have a couple of gold crowns or a bunch of silver fillings. These scanners are basically stitching together a bunch of 2D images, right? It's not magic. It's just a bunch of pictures. And it's got this bright flash that keeps flashing. Well, that reflects off the metal. And sometimes it has a really hard time reading as opposed to natural tooth, which is more kind of a matte finish. Okay? So in the same case, we've got this metal impression post or scan post that's in there. And the light can reflect weird, and you may not get the same level of detail. So the powder basically just gives everything a matte finish, and it helps the computer recognize it. And I've had some technicians tell me they don't need it, and I've had others that say, "Thank you for doing that," because it really gives me a much more crisp image and 3D model than I get with powderless systems. So I figure, what the hell? It's not really hurting anything. Walt doesn't seem to be too bothered by it. The powder is that stuff is the same stuff they use to write the letters on M&Ms. So unfortunately, it doesn't taste like chocolate, but at least it doesn't hurt you. Okay, so every little step for accuracy matters, especially with implants, because things are so precision to fit. So I think we're good. I think that'll about do it. Yep, that works. I'll go through here. And I'll copy that so I don't have to rescan again for the upper jaw. And I think we're in business, Walt. I'm going to take this little rubber housing out. These little bodies, those are disposable. We keep the post, of course. I'm going to go ahead and unscrew that. And here our click. Great. Slide that right out. I was at a lecture last year. Son of John Coyce. He's one of the more famous lecturers in the world in dentistry, and his son is starting to gain some traction. He's a prosthodontist. I think he's a prosthodontist and oral surgeon. So it was all on implants. And one of the things he talked about that was really important is to always clean the implant. Let's get a little bit back. A little alcohol. The interior of the implant, which is kind of hard to see. Let me get a picture for you guys. The interior of the implant is going to be a little dirty from surgery day. There's a lot of blood that happens when you're drilling holes in the jaw, right? So there's only so clean the surgeon can make the interior of the implant. So there we can kind of see down the hole, right down there. So down in that hole, that is the inside of the implant. You can see right in the center. That's where the screw is going to go to hold in the different abutments that we'll be using. If we leave that with a little crusted blood and powder and whatever else, there's a near guaranteed chance of contamination of that interface. So that little extra step, just a little bit of isopropyl rubbing alcohol, scrub it on the inside, make sure the exterior is clean. Cassie's always good about helping me keep kind of clean up our abutments and our screw, which we already did. There. And then we'll reinsert our abutment. One thing, we talked about how quickly the tissue collapses. Just in that few minutes, you can see how it's just pushing our crown back up. So Walt, you have to bear with me. Same thing as the last time. You're going to feel some pressure. I typically don't numb for this. I like the patient to tell me when they're feeling what they're feeling. I think we're back in. Let's check our floss. But that tissue is already resisting the crown from going back down. It would collapse that quickly. Yep, we're good. Okay, a little more pressure. So I'm kind of hopeful the lab can send us back to a screw retained. It's always better. Also for an anterior tooth, if there's, usually I'll let them go for a test drive. If they say, oh, I think in certain light, I noticed this, can you send it back? A lot easier without having to cut the crown off. If you can just unscrew it out, put a provisional back in, send it back to the lab for changes if needed. Very hard to match a single anterior tooth, especially when it's hollow like this. It's just a space. Trying to match the whole thing to look exactly like the natural teeth, in which his are not. They're not crowns or veneers. These are just natural teeth with some complexity to it. So the lab has the work cut out for him. So that's another reason that doing a screw retain would be really great. Because if we wanted to make any changes, we could. Well, that looks good, man. Let me double check the floss. We're going to fill our hole. Good. One newer technology, in dentistry at least, this isn't new in the world, that mechanics, I get all excited about implants, and mechanics are like, yeah, we've been doing that for 40 years. But they now do what's called an angled screw channel with Nobel. Had that for the last few years. Meaning that instead of having to go exactly down the long axis of the implants, they give you a special driver that has kind of like a three-dimensional octagonal kind of a geometric shape to it. It's not just a hex. That way I can, let's say the long axis of the screw or of the implant is this way, I can actually tighten it this way. I don't have to go straight in. So that allows us to do a screw retain crown, but I'm not actually screwing down the long axis. I'm screwing from a different angle. So I feel like if I was able to get almost to the entirely on the back end with this, with a conventional abutment, I probably will be able to do this one screw retain, because we can do an angled insertion of screwing this in with the final abutment. Okay, so we are all good to go. So I'll take another picture so you guys can see in there. This for any of your implant crowns when you're going to submit, whether it's a final. Sorry. There you go. I'll try to get your nose for a second. So if you picture what we're doing, I gotta fill that hole. If I put filling material in there now, it's gonna fill over the screw thread, the head of the screw, and I won't be able to access it. So you gotta cover it with something. A lot of docs will put a little cotton in there or floss. Cotton will actually be a little biodegradable. If you get kind of smelly, it's kind of gross. So I like to use Teflon tape or just plumber's tape. And that's not anything I came up with. That's just something I picked up, and we've had the best long-term results using Teflon. It's easy to pack, it's easy to use, and it's really cheap. You just go to Lowe's and get a roll of plumber's tape, and it'll last you a long time. That's better than cotton or better than floss, in my opinion, to pack over the head of the screw. A lot of pressure here, bud. Good. A little adhesive. And we'll do like a, you're going to use A1 composite? Yeah, let's do that. Put a little bit of adhesive in here just to make sure the filling holds. One thing you want to make sure of if you are ever going to put a temporary crown on an implant before the implant is integrated. So in this case, the temporary crown went on after the implant was integrated and ready to go. So we weren't really worried about how much pressure we were putting on it. But some patients will say, well, I don't want to have a gap there or wear a flipper or some other temporary solution. I want to have a crown on the implant right away. Like I said, let's say we took this tooth out. The integrity of the bone was good, and they felt like they got really good torque on that implant when it went in. You can put a provisional implant crown on the tooth the day that it's placed, or within a few days of it being placed. There's some precautions you have to take. You have to not put a whole lot of pressure on it when you're taking it in and out those first few months. Ideally, you don't take it out at all. You put it in the day it's placed, and you just let that temporary crown preserve the gum architecture and just stay like that, and let the implant heal for 3 months before you touch it. You have to make sure that it does not occlude with the opposing teeth. You don't want it in the bite at all, and really, you don't even really want them using it that much, biting into carrots or apples or anything. You want to just make sure they're cutting their food up, and it's there for talking and smiling. It's not really there for biting into quite yet as that implant heals. We'll go ahead and bite down and open. Tap your back teeth together, up and down. Teeth together, open. I'm a little bit heavy back there. As far as integration of the implant goes, if you're into good bone, it's usually, my understanding, in the first couple of weeks, that primary torque, just the force of the threads in the bone, is what's holding it in. And then all that bone turnover, remember all the osteoclasts and blasts and all that exciting stuff, they start doing their magic. The bone gets really soft, almost like it does around a tooth with orthodontic movement. So if you were to put enough pressure on an implant a month into it being placed, sometimes you can just pull it out. Yeah. Okay, so it's a lot of turnover going around there. So you really want to make sure you're putting a provisional in, you do it at the beginning or you wait till the end. But that couple months in between of integration, you don't want to touch it. I'll go ahead and bite down. That's good. So again, I'll just leave a little sliver of space here. All right, my friend. A lot of mess here. Let's give you an inch out here. Look together. Get you some chapstick. And that's going to do it. You want to look at the scans here. I sent it to the model processing, so it shows us where the byte's occluding. It shows us that impression post where it is. It will ask you to, so I'll go back here, the byte registration. I'll show you again for lower jaw. And I can click to ask you to click on the scan body head, make sure the computer knows which one's the implant. You can see our two notches are lined up. It overlays the scan of the gum tissue, so it'll tell the computer exactly how things were when it came out and show everything we need to go. We'll send it to Connect. It'll go to the Connect portal that the company has linked up with the lab technicians. You write your lab script, type it in, any special instructions, delivery date, and then it gets emailed and they can start working on it right away. Usually this process, if you're using an out-of-state lab or a sophisticated lab, it can be a month and a half, especially not right now with COVID, where some of the supply chain's a little messed up. So we're probably going to appoint him around middle of December. We may get it sooner. If it's a little more of a straightforward single color crown that I don't have to do a lot of artistry with, sometimes we can get it back in a couple of weeks. But something like this, it's going to take some time. So we'll send that to the lab, email them the file, and they'll usually digitally print at least the impression coping, the abutment. They'll print the substrate of the crown, and then oftentimes with something like this, where the porcelain is more customized, they'll then have the lab technician do all the artistry of overlaying the different lobes and layers of translucent ceramics, and they'll do all their magic by hand. You can't mill and print everything. Sometimes it still takes human touch. Which will for this. So that's about all I got. Any other questions?
Let's see. Yeah, any last questions, guys, before we end? You can speak up and you can just talk now instead of typing it in.
All right, we got a question. What procedures do you perform most often during the day?
Just in general dentistry?
Yes.
Oh, geez, that's a good question. Exams? The bread and butter still. We're still solving the main issue, which is gum disease, cavities, fractured teeth, all that stuff. So a lot of crowns, a lot of fillings, of course, hygiene visits, which our staff is taking care of. I do a fair number of implants. Kind of depends on what you want to make your practice into. You can kind of pick. Some people get really into like sleep dentistry and airway, so they're spending like a significant amount of their day making oral appliances. Some people get really into cosmetics, like his dad. So they're spending good chunks of their time doing veneers and full mouth rehab, stuff like that. Some people get really into prosthodontics, so they're doing a lot more all on 4s, all on 6s. For me right now, it's a lot of bread and butter. I would say probably 80% of my day is just fillings and crowns as far as procedures go. Some surgery, some extractions, and then the rest sophisticated dentistry like implants, veneers, and whatnot. So kind of a mix of all. That's one of the things about doing general. You get to kind of make it yours and you get to pick, which I like. You get a lot of variety. I don't do any root canals. I've found that it takes me forever, and I still can't be sure that I got it right because I don't have a microscope, and I'm busy enough to fix the teeth. So we refer to endo for everything. I remember speaking to the chair of endo at Houston after a lecture, and she was talking about how hard it is to do an incisor root canal and canine root canal, which are supposed to be the easy ones. Then I remember asking, like, what would you refer then? She said, everything. So that's not to say all of you can't do a great job doing root canals for your patients, but I got to the point where if I'm at the point where any friend or family or myself needs one, and I would insist they go to an endodontist, I should probably just tell all my patients that. So I got to that point with that. I don't do any Invisalign orthodontics yet. Again, we refer to specialists. May get into that at some point, but it's kind of what you make it. You have the right technology. Let's say you get a good CT scanner, you can take a good cone beam of bone and plan everything out. You can place your own implants. You don't have to go to a surgeon for every single one. But for me, it's mainly restorative. You can get really busy just doing restorative dentistry and make a great living at it and enjoy it without having to do all the specialty work. Depends on what you want.
Yeah. Cool. Yeah.
Anything else?
Is there anything else?
No, that's it for right now.
All right. Perfect.
Yep.
Well, thank you, Dr. Heck. We all appreciate it a lot.
Very welcome. Y'all feel free to email or call with any questions. We'll be here, okay?